Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Hello there, and welcome to Helping Patients Implement a Plan for Nicotine Cessation. This activity is obviously on Medscape, and I'm really proud to be part of it. My name is Chuck Vega. I am a clinical professor of family medicine here at the University of California, where I also serve as an assistant dean in our School of Medicine. I also work in the largest safety net clinic in Orange County, California. I've been doing that for 29 years. And while we don't have high rates of smoking here in California, I certainly every month help smokers try to quit, and those who use other nicotine products, vaping as well, try to quit. So we're going to be talking about some of the best practices that we can do. I think there's no single way to approach this, but I'll try to provide some principles that I found have worked both in terms of the evidence and are part of national guidelines, but also in my practice as well. So overall, we just want to remember our goal is to be completely free of nicotine and its influence. So it is one of the most addictive substances, known to man. It is as addictive as opioids. So of course, quitting is really hard. The more you smoke or the more you vape, and the longer you've done it, the harder it is. So there might be some baby steps in there. Folks who are very heavy smokers, I usually try to get them to cut back. It's also though when you're doing that, you're creating a mindset. It's not just the fact that you're reducing the amount of nicotine and its addictive properties. It's also you're creating a mindset of winning for the patient, that they can do this, and where they become self-effective. And that's really outstanding. I think and when you get that, when your patients really bought into it and they see that they can control their smoking habit. Guess what? They can also work on their diet later, or their physical activity, or sleep, or some of these other really important domains of lifestyle that have such a outsized effect on health. So let's think about making a plan. And the old model is that we ask and make sure we know the patient, whether they're using nicotine or not. Then we advise them about the risks and the dangers. Then we assess their willingness to change, assist them in trying to set up a plan to make that change, and then arrange for help. That could be help like counseling. It could be help like national services that help folks quit nicotine products. It certainly could be non-pharmacotherapy, or it could be pharmacotherapy. I would just tweak this model a little bit. Actually, I ask then assess. So, oh, you're smoking? Okay. You ever think about quitting? Why or why not? I really want to start with a patient because their goals, as we're about to discuss in a minute, can be quite disparate in terms of why they want to quit smoking. And so I think starting with their perspective is going to yield the best. One, it gives them a voice so they feel like they're more heard, and that's part of empowerment. So really helping them to become more self-effective. But it's also, I think, a much more direct way so I can help them and understand, oh, it's because I want to save money, because I've got, we're going to have a child, and I don't want to smoke around my girlfriend who's pregnant. Or, there's a lot of reasons, which I'll cover in a minute. But starting with the patient's perspective is always, I think, a lot more linear. And I, like you, probably have very short visits. I don't have a lot of time to discuss these things. Usually, when I'm thinking about smoking cessation and giving this advice, it's not the first or second issue of our discussion. Those were, my headaches and my diabetes and my hypertension. And, what do you think about this vaccine series coming out? And then I'll get to, by the way, do you want to talk about your smoking today? Luckily, there are tools, and I'll just call out smokefree.gov. This is a really nice and, again, evidence-based blueprint for helping someone quit. So it provides a lot of resources. So it's a go-to. It's set up by the U.S. government. So therefore, I think it's vetted, but it's also, I think, very patient-centered, and it's fairly easy to use and has some valuable resources. Of course, I want to think about setting a quit date with my patients. I'm pretty lenient with the quit date. It's I think that, maybe it's their, the big ones that people like to focus on would be, January 1, new year, new resolution, new leaf, or my birthday, not my birthday, the patient's birthday. But really, if they want to do it on my birthday, I don't care. As long as they quit, I'm happy. I do try to get it though done, and once I've got somebody really primed to quit, we've talked about it. Maybe we've had 2 or 3 sessions where we've talked about smoking cessation, or nicotine cessation, and at that point, that we're really at that point, and they say maybe in 6 months I can do it. It's like, well, why not 2 months? And try to identify a week when there's going to be lower stress, when they're not going to be busy trying to do a million things, because that's kind of setting up for failure. So we all have some weeks that are lower key. That's the time to try to quit. And even if they can't set a date, I'm still going to help them with a plan. Um, I'll talk about motivations to quit, but one of the big ones is cost for my younger smokers. This is one of my go-to areas. So if you're a pack per day smoker in the United States, you're spending anywhere between $240 and $360 a month on cigarettes, which could be used for so many essential. Maybe it's an essential kind of purchase you need. I need to pay the rent, keep the lights on, pay my insurance, stuff like that. Or maybe it's something you can splurge on. Hey, I want to, gosh, with the savings there, I could buy seasons tickets to a sports team or something like that. Maybe you can't do that, but depends on the sports team. so 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 I think that, but again, you're using your patient's motivation. For a lot of my younger patients, and some of my older patients on fixed income, just realizing the economic cost is important. So this is a more complete list, though, of reasons, that most common reasons on smokefree.gov that folks might want to think about quitting. And I'll just call out a couple. We're seeing more and more folks who are doing it for the environment. Again, that tends to be a younger age group in my practice. Another worry is pets. So many folks are really into their pets and don't want to harm their pets. And so, therefore, if that's a motivation for them, certainly I think I'm going to go with it. And then the last one I'll call out is just the idea of taking back control. And I think that that's been so important in our public health advertising against nicotine and nicotine products, that these large corporations have for decades really manipulated, particularly young people, but all people, and but I guess with a focus, unfortunately, on young people and people of color, in particular. And that's really insidious. And so the idea of taking back control, I think, is really important. And again, that leads right to that through line of empowerment. And I'm very open with my patients. Hey, this is one of the hardest things you can do, but if you do it, you can, you'll find that you can do so much else. So this is going to be a real win for you. There's nothing like nicotine cessation, particularly smoking cessation. It's the best thing you could do for your health. So when I ask my patients, "Are you interested in quitting?" No, I'm not. I'm not going to quit. I'm just not. No, don't want to do it. I know it's bad for me, but I want to do it. Well, it is bad for you, and so I share. It's the best thing you can do for yourself, and I don't let go. It's if it's okay with you, I'm going to bring it up again, because maybe at some point in the future you might change your mind. Fine, doc, whatever you want. But they'll know you care, and then I will revisit it. There's going to be some lull in our visits over the next year, where I'm going to say, hey, have you thought about this anymore? And keep working on it. Eventually, you might get there. I've had patients who have smoked for 30 or 40 years, but they did quit successfully. It's important to know about the and be honest and open about the fact that most folks who try to quit don't achieve abstinence from nicotine, because there's a million things that lie in the way. There's stress, there's social influences, then there's very powerful pharmacologic biochemical influences as well, that lead to poor quit rates. But I think by identifying these potential pitfalls at the outset, as well as supports that can help during these challenges, I think is really important. So I think that knowing the habits, and where particularly it's so important for the person to smoke after they eat, when they first wake up, before going to bed, maybe on a break at work. It's those are the times where you really want to plan around them and think about ways to change your environment. So you have to really think hard about the ones where if you identify, particularly, these are my most important cigarette moments per day. Hopefully it's not 12 of them, but there's like usually 2 or 3. And then you just have to strategize with the patient other things they could do. you're going to be outside your normal behavior pattern a lot. You're going to be outside probably your house or your apartment a lot because unfortunately, if it's after a meal, it's just harder. So yeah, to just sit there. If you so, I really want to get them active. So I want them very engaged with something, engaged mentally, engaged physically, so they're not having those cravings and they can focus their body and their mind elsewhere. And I think that part of that is giving pharmacotherapy. So I'm a big believer in this. I think we underuse it. Um, for prescriptions, varenicline, it's bupropion can be effective if they have depression. And one thing that's not done a lot, but actually does make sense and has some literature behind it, is you can actually use both of those medications together. Varenicline and bupropion is more likely to help somebody quit smoking versus bupropion alone. So they do have different side effect profiles to some degree. So I think therefore that can be a reasonable choice too, particularly if they failed monotherapy before. You can use dual therapy. And then nicotine replacement therapy is very important, whatever the patient prefers. Most of my patients prefer the transdermal, but there's something you said for the gum because it gets that quick hit as well. I think the keys are if you're going to start one varenicline or bupropion, you want to start at least 1 week before they have their quit date. And then they're safe drugs. So I have patients taking them for months, but usually within a couple months, you can discontinue those medications, and then the nicotine replacement therapy even before that. So I think it's important to consider a team approach as well. It's challenging if it's just the patient doing it by themselves. It's great if you as a clinician are there to help guide them, but you can have staff helping. So behavioral support is really important. So mental health support can be very important. Having a pharmacy involved because there are a lot of OTC nicotine replacement therapy options. So that's just one great way that they can also be part of this effort. Nurses with a background in counseling and providing advice can be really helpful as well. And I think just look at what the patient has around them. So who is their support team? Who are they living with? Who are they depending upon? Are those people smoking? Is that another trigger for you to smoke? Or are they're really supportive and they're really trying to help the patient? And maybe you can get not one but several members of a family to try to quit all at once, which is great. In family medicine, that's ideal. I have had couples stop smoking. You're really making a difference in terms of morbidity and mortality for those people. And so think about just being patient centered and being team oriented throughout the process. I always follow up. I use telehealth a lot for these kinds of visits where it's just I really want to focus on what's happening around their quit date. So I will try to call around on or around shortly thereafter, after their quit date, and check up on them. Many times they haven't actually quit when I call 3 days after their quit date. So we talk about it's first obstacle, but we're going to overcome this. And generally they'll set a new date and stick to it. And then so I just keep following up and providing more support and giving them lots of resources, online resources, national resources. There's a lot of reputable free services sponsored by NIH and the CDC that can be quite helpful for folks and provide free telephone support as well. There's online support. There's chats available. So yeah, and there's also group therapy which can be helpful. It's not a one size fits all approach. Everybody's busy, so I always try to take what the patients really feel is the most valuable resource for them, emphasize that, and use that to its full degree. And with that, I think that I generally have had a lot of successes, and a few that we're still working on. But I think the key is don't let it go. This is the best thing your patients can do for themselves. And like I said, it empowers them to do other changes that are healthy as well. And in terms of my satisfaction as a clinician, just going through that process and being patient centered, I feel it really helps me connect with them more, and therefore I think feel more fulfilled in my practice. Thank you very much for participating in this relatively short activity. You can find more useful tools and resources at the right hand of the page. Hopefully, you found it helpful and pragmatic for your practice. Take care, everyone.